Yes, good afternoon, everyone. I'm Dr. Wahabzai. I'm a third-year resident here. Very nice to see all of you. Welcome, class of 29, right? Yeah, okay, all right, good. I hope especially the ones that are in the inpatient service with us are enjoying their time as well, okay?
I am accepting to.
Okay, wow, yeah, it's a big class, yeah, okay. All right, so let's get to it. We're talking about atrial fibrillation today. So this lecture is mostly composed of clinical vignettes, clinical things that I think that are going to be very helpful for you. I know when I was the first year, there's a lot of stuff that I wish I would have known about atrial fibrillation that I've put together here in this presentation for you guys. So I hope it's very beneficial to you and that you go back to it as well, okay? All right. Some of the questions that you get in the inpatient service while you're in the ICU or from your attendings may come off of this, okay? Stuff that I've been asked as well, okay? All right. So let's get to it. In terms of the heart conduction, in normal conduction, the electrical impulse begins in the SA node, spreads uniformly through the atria, producing a P wave and coordinated atrial contraction. In AFib, premature electrical impulses most commonly originate from the pulmonary veins, entering the left atrium, although less commonly they may arise from other sites as well, the right atrium also. And this is worse in a susceptible atrium, person who has an enlarged or fibrotic atrium. The impulses then will break into multiple reentry wavelets. Instead of one organized wave of depolarization, there are hundreds of chaotic wave fronts circulating throughout the atria. The AV node blocks many of these impulses, allowing only some to reach the ventricles. This produces the characteristic irregular ventricular rhythm that you see in atrial fibrillation. So atrial fibrillation is a supraventricular tachyarrhythmia characterized by rapid electrical activity in the atria, resulting in ineffective atrial contraction and irregular conduction to the ventricles. Right, so why is knowing about atrial fibrillation important? It's the most commonly treated cardiac arrhythmia, actually. According to a study, Atria, Anticoagulation and Risk Factors in Atrial Fibrillation, the overall prevalence of AFib in the US is 1%. 70% are at least 65 years old. The prevalence of AFib was 0.1% among adults less than 55 years of age. Most AFib develops because of atrial remodeling, some of what I mentioned to you, atrial stretch, fibrosis, inflammation. Important modifiable risk factors include hypertension, obesity, lack of fitness, sleep apnea, alcohol, diabetes mellitus as well. Non-modifiable risk factors include genetics, male sex, and age. Cardiac structural findings that increase risk include frequent atrial ectopy, short bursts of atrial tachycardia or atrial flutter. High-risk clinical conditions include heart failure, valvular disease, coronary artery disease, and hypertrophic cardiomyopathy as well. So classification of AFib. Paroxysmal AFib is AFib that's intermittent and terminates in less than or equal to 7 days from its onset. Persistent AFib is AFib that is continuous for greater than 7 days. Long-standing persistent AFib is AFib that is what? Who knows? Who can answer? Exactly. Yeah, you're right. Greater than 12 months. Okay, very good. And then what is permanent AFib? What is that defined as? You know? Well, Maria? Anyone else in the first year brave enough? Permanent AFib.
Is it refractory to treatment, cardioversion, or efficiency?
Exactly, yeah. It's a term used whenever the patient and the clinician make a joint decision to stop further attempts to restore and maintain sinus rhythm. Okay. All right, so this is a image of a normal EKG strip. Here you see this is the actually I don't think my laser is not appearing. Okay, right here is right there is the P wave that you see here. This is a P wave, which signifies atrial contraction. And then this is the QRS here, of course, that signifies ventricular contraction. And then the T wave here signifies the ventricular relaxation, okay? And then you have these are R waves that are regularly spaced out together. So you have a P wave in front of an R wave, and the R waves are regularly spaced. This is how the RR interval is regularly spaced. This is what you expect from a normal EKG whenever you look at it, okay? And then don't worry, you guys will get plenty of EKG training as well. I think there's going to be an EKG boot camp also upcoming if it hasn't been done already, right? Not done yet, yeah. So they'll grill you guys on this, okay? So this is just to start you off. All right, good. All right, so this is normally the speed of the EKG regularly is at 25 millimeter per second EKG. This is a single strip here that you see. What you see in terms of atrial fibrillation is the hallmark features irregular ventricular rhythm, evident by the variation in the R to R intervals. You can see how these R to R intervals are different in this strip. There are also no discrete P waves preceding the QRX complexes. This reflects the absence of organized atrial depolarization. Instead, the baseline contains these what are known as fibrillatory waves, these F waves that are located here in the baseline. This represents chaotic electrical activity within the atria. The QRS complexes are narrow and of uniform morphology, indicating that ventricular activation is occurring through the normal Purkinje conduction system. Normally, the EKG machine will give you the rate, but you can also try to estimate it yourself. In this 25 millimeter per second EKG, you can count the large boxes. 15 boxes will equal 3 seconds, and then you can multiply that by 20 and get your rate off of that, okay? So in this case, there's like 8 QRS complexes and 15 large boxes, and you can estimate the rate is like 160, okay? So this is consistent with what's referred to rapid ventricular response, all right? When interpreting an EKG for atrial fibrillation, systemically look for the combination of the absent P waves, an irregular R to R interval, and F waves. The presence of all of these is diagnostic for AFib. All right, so when you talk about AFib, one of the things that you have to take into consideration, of course, is the risk of stroke to the patient, right? Yeah. So the left atrial appendage is a normal finger-like muscular outpouching from the left atria. You see it right here, where I've circled it. Right, it develops from the embryonic primitive atrium. It's present in all individuals, although its size, shape, number of lobes, and orientation vary. The reason it's important, of course, is in the AFib, because the site of common thrombus formation, okay? This is where the blood can become stagnant, form into a thrombus, and then unfortunately it can travel elsewhere, all right? All right, so one of the important apps that we use a great deal in the inpatient service and here in residency is called MedCalc, okay? This is gonna have a lot of your calculators whenever you're determining stroke risk to a patient, whether you should place them on anticoagulation or not. You can do this CHADS-VASc score, okay? Stroke prevention, of course, is cornerstone of atrial fibrillation management. The CHADS-VASc score is the most widely used tool to estimate annual stroke risk in patients with AFib and to guide decisions regarding oral anticoagulation. The score incorporates the following risk factors: heart failure history, hypertension history, age, diabetes, sex, vascular disease, and of course, a history of stroke, TIA, or thromboembolism. Now, going on to the next slide. All right, so this is right off of the MedCalc app right here. This is the CHADS-VASc score. You can see here the age here, less than 65 will give you 0 points. 65 to 74 is +1, greater than equal to 75 is +2. And then coming to sex, you can see here that female is already a +1 actually. So in terms of gender, females already get +1, males are 0. CHF history, of course, the highest you can get here is a +1. Hypertension history, +1. Stroke, TIA, thromboembolism history, a +2 is the highest. And then vascular disease history, prior MI, peripheral arterial disease, or aortic plaque is a +1. And then diabetes history can give you a +1 as well. So you should start anticoagulation in men with a score of greater than or equal to 2, and in women greater than or equal to 3. Okay? The score ranges from 0.2% annual risk of stroke to 8 for a man, which is 10.8% risk per year. And for a female, it can go up to a score of 9, 12.2% risk of stroke in a year. Okay. Whenever you decide to place a person on, you're deciding to place a person on anticoagulation, there's also another score that you look at as well. It's called the Hasbled score. And this is also, of course, found in the MedCalc app. So AFib treatment requires balancing the risk of thromboembolism against the risk of bleeding. So the Hasbled score is used to estimate the risk of major bleeding in patients receiving anticoagulation. The score takes into account hypertension, renal disease, liver disease, stroke history, prior major bleed or predisposition to a bleed, and labile INR, age greater than 65, and medication predisposing to bleeding. So on the next slide here, on the MedCalc app here, we'll see the score here, the Hasbled score. You can see hypertension here, renal disease, liver disease, etc. Down here. So the calculator gives you a point score with associated percentage for risk of bleed. The score ranges from 0, low risk, to 9, very high risk of major bleeding. All right, so in terms of medication that's used for anticoagulation, these are direct oral anticoagulants, the preferred anticoagulants for most patients with atrial fibrillation because of their predictable pharmacokinetics, allow fixed dosing without routine INR monitoring. They have fewer food and drug interactions and are greater convenience. The two most commonly used that you'll see are apixaban and rivaroxaban. When used for anticoagulation in AFib, Eliquis is dosed 5 milligram twice daily. The medication may be dosed 2 milligram twice daily when patients meet at least 2 of the following 3 criteria. Who knows the criteria? Huh? A little bit older. Okay, 80, yeah. So age, so the first is going to be age 80 or greater. Next criteria. Yes, creatinine is also a criteria. And what does that need to be? Exactly, creatinine of 1.5 or greater. And the weight, perfect, yeah. Okay, so my friend here is helping you. All right, yeah. All right, so a weight of less than 60 kilograms. Okay, so if a person meets 2 of the following 3 criteria, age 80 or greater, body weight less than 60 kilograms, or creatinine greater than or equal to 1.5, you can dose the person at 2.5 BID. Okay. And then rivaroxaban is commonly dosed at 20 milligram once in the evening. Okay, so that's that can be beneficial for a person who only wants to take one-time dosing. All right. And then talking about anticoagulation, something that we use commonly also in the inpatient service. Enoxaparin is an example of a low molecular weight heparin that's used very commonly for anticoagulation. You'll see us using it quite often in the inpatient service. It's favored as a bridging anticoagulation while initiating warfarin until the INR is therapeutic. It's used commonly also for perioperative anticoagulation when anticoagulation needs to be temporarily interrupted for surgery or invasive procedures. It can be discontinued 12 to 24 hours prior to procedures. So this medication, it's administered subcutaneously, okay? So it's subcutaneous by injection. And then, so patients, in this case, for example, patients are not receiving any fluid volume. So this is especially important if you have a person on daily fluid restriction. You can actually favor low molecular weight heparin versus the unfractionated heparin, okay? So unfractionated heparin is favored for anticoagulation, also similar. It can be used bridging whenever you're trying to initiate warfarin. It's preferred when rapid anticoagulation and also rapid reversal are needed. So it has a very short half-life, approximately 60, 90 minutes. So the medication is a continuous IV drip that requires dose adjustment by the patient's nurse. It's based on looking at the patient's PTT or anti-10A for monitoring, okay? So a benefit of a low molecular weight heparin is that you give it as an injection. So if you have a patient that you want to fluid restrict, you're not giving them this heparin drip, which is a continuous drip, and they're getting 300 or so plus cc's of fluid in one day while they're getting a drip, okay? So if you want to keep them better fluid restricted. But the heparin does have the benefit, of course, that it has a very short half-life. So if you want to cut it off and reverse it, and you want the person to be reversed quickly, it's very beneficial, okay? Like the person's going to go to surgery soon, okay? And then, of course, the next medicine we have here that's a very old, very popular medicine from the past, especially warfarin is preferred in valvular AFib, okay? And valvular AFib, but nowadays refers specifically to patients with presence of moderate to severe rheumatic mitral stenosis and mechanical heart valve, okay? So in these patients, you have to use warfarin as your anticoagulation of choice, all right? You cannot use the other DOACs. And then because clinical trials have shown that versus DOACs, the DOACs were inferior and associated with worse outcomes, okay? So compared with DOACs, warfarin requires it's more inconvenient for the patient, requires regular INR monitoring, has numerous drug and also dietary interactions as well. So sometimes it can be difficult to get a person to a therapeutic INR when you give them warfarin, so you have to watch them very closely, follow up very closely with them. So another big thing after anticoagulation, of course, is rate control. Yeah. So these are some of the beta blockers that are commonly used for rate control. Some of them, of course, are more favored than others. Metoprolol is beta-1 selective. Tartrate is the immediate release formulation. It's dosed PO BID. And succinate is the extended release version. It's dosed PO daily. The benefit of metoprolol tartrate is also that it comes in an IV formulation. So you'll use it also in the inpatient service quite a bit acutely for a patient like an AFib RVR. You can use it because it's an IV formulation, okay? So metoprolol is the most commonly used of the beta blockers for rate control. Acutely, the IV formulation, it's the metoprolol tartrate IV formulation. It's given as a 5 milligram IV bolus, and you can do it Q10 minutes up to 3 times, okay? So 5 milligram IV Q10 minutes times 3 is how you'll see it in the computer system, all right? And then the onset of action is like 5 minutes for that IV. And then bisoprolol is another beta blocker that's worth talking about as well. It's highly selective of beta-1 receptors. So it's a very good choice for people that have soft blood pressure readings, okay? So if you work with Dr. Agocha, the heart failure specialist, you'll see that he commonly prefers this beta blocker for his heart failure patients that have very soft blood pressures, okay? So if a person has a soft blood pressure reading, so you have to think about these different issues that the patient has, and you can select different beta blockers based on that, okay? So this is a good choice for people with soft blood pressure readings. It has is very highly beta-1 selective, has little effect on beta-2. And then carvedilol is a non-selective beta receptor inhibitor. It has also alpha-1 receptor inhibition actions as well. It has the greatest effect on blood pressure because of that, okay? Because it's non-selective beta and also alpha-1 inhibitor as well. It comes only in the PO form, all right? So you won't find that in IV. And then the next one, atenolol, is a beta-1 selective. It's also only in the PO form. It's not used very often. Esmolol is a beta-1 selective. It's only an IV formulation only. And one of the benefits is that it has an ultra short half-life of 9 minutes. I've only seen it used mostly just in the ICU for patients with uncertain hemodynamics, and it can be titrated and also stopped very rapidly, okay? So that's the benefit of that drug. You'll likely see it only in the ICU. Nadolol is a non-selective beta receptor inhibitor with a long half-life, 24 hours. It's dosed once daily. It's only in PO form. I don't see that commonly used either. Propranolol is also a non-selective beta receptor inhibitor. It comes in PO and IV formulation, immediate release, and extended release forms. I don't see that commonly used either for rate control. So the choice of, as you found now, the choice of beta blocker may also depend on other comorbidities of the patient. For example, in patients with also having heart failure, reduced EF, you may see metoprolol, succinate, carvedilol, or bisoprolol favored because they're part of the GDMT for heart failure, goal-directed medical therapy, and they help to reduce mortality in those patients, okay? Right, continuing with the rate control, now let's talk about the non-dihydropyridine calcium channel blockers. They work by blocking the L-type voltage-gated calcium channels in the myocardium, the SA node, AV node, and vascular smooth muscle. This has the effect of reducing heart rate, so it has a negative chronotropic effect. It decreases myocardial contractility, so this has a negative inotropic effect as well. It'll also lower the blood pressure as well, as I mentioned. In terms of formulations, PO and IV are available. Out of the two, diltiazem is used more frequently. In PO format, it's commonly dosed in extended release form. You'll see it in doses of 120 or 240 milligram daily. And then in immediate release form, it's dosed at like 30 milligram QID. To start off with. For acute AFib RVR in the hospital, you'll see that clinicians will commonly use a bolus of diltiazem. They'll give 10 milligram IV times 1. The onset is 5 minutes and peaks at 15 minutes, so they'll wait for at least 15 minutes to see what effect it's had on the patient. You can repeat the bolus and also give another second bolus as well, another 10 milligram IV bolus. And then if the heart rate is not controlled, and then you can also take the person and place them on a diltiazem drip, so that the drip starts at 5 milligrams per hour, and it comes with also you have to make sure that you have blood pressure checks as well every like 10-15 minutes while the person's on the diltiazem drip, and then you'll see this medication's favored in patients. These non-dihydropyridine calcium channel blockers are favored in these patients that have like COPD and asthma, okay? All right, so another older rate control medication is digoxin. This works by inhibiting the sodium-potassium ATP pace pump in the cardiac myocytes. It also enhances vagal tone, thereby slowing AV nodal conduction and increasing AV nodal refractoriness, okay? So this will slow the heart rate down in this method. The medication has a narrow thing about this medicine, it has a very narrow therapeutic index and can result in drug toxicity, okay? So you have to be careful about that. Unlike beta blockers and calcium channel blockers, though digoxin doesn't cause vasodilation, its positive inotropic effect helps maintain or increase cardiac output, resulting in little or no reduction in blood pressure. So that's important for another patient. If you have a patient with soft blood pressure and you don't want to use the beta blocker, you don't want to use the calcium channel blocker, you possibly might want to use the digoxin, okay? So that's an option. It's not used as commonly, as mentioned, as the beta blocker and non-dihydropyridine calcium channel blockers. It's seen used in patients with AFib and heart failure. Acutely, you can give a person a 250 microgram one-time dose, and then you can wait an hour, see if you're able to control the person's rate. If not, you can repeat another 250 microgram dose, okay? IV.
The indication in like kidney failure.
Digoxin, do you know? Yeah, exactly.
So it's potassium.
Yeah, of course, all of these medications, you have to be careful about contraindications. There's so much that you could say, yeah, about each of them, about contraindications. Of course, yeah, you have to be careful with potassium as well. She was asking about renal metabolism, yeah. Oh, okay. Yeah. Just be careful about contraindications with all these medications. Yeah. She was asking, could I give it to a person with kidney issues? All right. Now, moving on with rate control. Amiodarone is a class 3 antiarrhythmic. It primarily blocks potassium channels, prolonging cardiac action, potential duration, and effective refractory period in atrial and ventricular myocardium. It doesn't have much effect on blood pressure either, so it could be used possibly in a patient with soft blood pressure as well. It's thing about amiodarone is that it can chemically cardiovert the patient into a normal sinus rhythm, so you have to be careful about that. This is the main difference from the other medications. It's given IV as a 150 milligram bolus, then transitioned into a drip. So consult with the cardiologist prior to giving amiodarone, okay? Ask the cardiologist if it's acceptable. Yeah, exactly. This one would switch the rhythm as well. And then let's talk about what if a patient can't take any anticoagulation? You know, has blood scores too high. You don't find that they're eligible for anticoagulation. So this is a procedure that we performed. This right here is the left atrial appendage that I spoke about earlier in the lecture. The Watchman procedure is minimally invasive. The catheter is it's a catheter-based intervention used to reduce the risk of stroke and selected patients with atrial fibrillation for whom, as mentioned, anticoagulation is contraindicated or the person doesn't wish to have long-term anticoagulation, okay? During the procedure, a catheter is going to be inserted through the femoral vein and advanced into the heart. The catheter is guided across the interatrial septum into the left atrium, where a small device called the Watchman is deployed within the left atrial appendage. The site where this is the site, of course, as mentioned, where most blood clots form in these patients with AFib. The device will seal off the left atrial appendage, and the scar tissue will grow around that area, so it'll become completely sealed off over time. The patient then is going to be placed on anticoagulation with aspirin and also aspirin as well as a DOAC, for example. And then the person will follow up 45 days and get a TEE conducted, okay? The TEE, the purpose of that is to evaluate the positioning of the Watchman device, all right? So they'll still be on some anticoagulation up to that point, okay? And then from there, they'll decide to remove them off anticoagulation if everything looks fine, okay? So you'll see that commonly mentioned in the notes by EP and by cardiology, right? And then let's talk about unstable atrial fibrillation, okay? Of course, your first year residence, anytime you have a patient, of course, that's unstable in inpatient service, you know that you're part of a team, of course. Yeah? You're not expected to deal with the patient alone by yourself. First, some of the signs of an unstable atrial fib patient with RVR is that this has different treatment than a stable AFib RVR patient. But in unstable AVR, they'll commonly find that the patient's hypotensive. The first thing to do is activate the rapid response team of the hospital, okay? So activate the rapid response team. They'll bring the nurse practitioners. They'll also bring several nurses. They'll bring a crash cart and everything, okay, to the patient's room. So they'll respond very quickly. In terms of choice of treatment, you're going to do synchronized cardioversion, okay? That's what's done, and it's 200 joules synchronized cardioversion, and then they can repeat that as well if they need to, okay? And this commonly is handled by the rapid response team, and your other team members also will show up, okay? So make sure that you contact your attending, and the first thing you do is contact the rapid response team. You tell the nurse, okay? And they'll activate it. Going on by, okay. All right, in terms of now rhythm control. In patients with AFib, shared decision-making with the patient is recommended to discuss rhythm versus rate control strategies, okay? In patients with a recent diagnosis of AFib, like less than 1 year, rhythm control can be useful to reduce hospitalizations. Second, my thing is frozen. Can you help me here?
Is it not working?
Okay, now it's come back, okay. All right, so as I was mentioning, in patients with recent diagnosis, There you go. Okay. All right, so as I was mentioning, that rhythm control may be sought, for example, in patients with recent diagnosis of AFib less than 1 year. Rhythm control can be useful to reduce hospitalizations, stroke, and mortality risk for the patient. Rhythm control can also be useful to improve symptoms in symptomatic AFib patients. So there's different forms of rhythm control. These are three of the most common here that I've mentioned. First is planned synchronized cardioversion is performed by first performing a TEE to rule out a left atrial appendage thrombus. And then the patient is placed on anticoagulation, and the anticoagulation is going to be continued for at least 4 weeks time period, okay? And then secondly, catheter ablation is a minimally invasive procedure performed by advancing catheters through the femoral veins into the heart under fluoroscopic and three-dimensional electroanatomic mapping guidance. The electroanatomic mapping is generated by electrode catheters that are advanced into the atria and display the electrical activity of the atria. So you'll see this commonly by the EP doc that you'll say that he's going to do electrical mapping of the patient. This is what he's talking about, all right? All right, so the EP cardiologist is then going to ablate areas of abnormal electrical activity that he sees when he performs the electrical mapping, okay? After this procedure, the patient's also continued on at least 4 weeks of anticoagulation. This is for both of them because this is due to increased risk of thrombus formation having these procedures. The person can experience something called transient atrial stunning, which may occur after restoration of sinus rhythm, in which stagnant blood, especially in the left atrial appendage, may cause thrombus formation. Okay, so this is the reason why even after they do this, they continue anticoagulation for up to 4 weeks. Okay, and there also might be inflammation in the areas also, for example, that have been ablated post-procedure. And then the final procedure here that's mentioned is the maze procedure. It's more invasive. A surgeon creates a series of precisely placed lesions in the right and left atria using radiofrequency energy or cryoablation. These lesions heal into scar tissue, which blocks abnormal electrical pathways while allowing normal conduction from the SA node to the AV node, okay? Here in the hospital, you'll commonly see that they'll talk about doing synchronized cardioversion and catheter ablation, right? All right, so now, the intern cardiologist. Do you know about that, Dr. Abdallah?
Not sure to be honest. The maze goes to be entered.
Yeah, I didn't read about that either. Yeah, I haven't read about that either. Okay. All right, so now some things that will be helpful to you guys in clinical practice here as residents working here, okay? So I'm working in the inpatient service now, so this is especially useful for my interns also that are working with me. I'm going to show you guys how to maneuver through the Epic EMR. All right, so whenever you pull up your patient, you click on your patient's name, you'll see this here. You open up the patient's chart Epic, you see the screen here that has up here at the top is going to be your, let me get out the laser. Up here at the top is going to be your tabs here. You click on orders up here. And then here in this box, you can start typing in your orders. So you see a patient here, they're an AFib, and what do you want to do? You've decided already with your team that you want to do anticoagulation. Of course, your attending has approved everything, okay? Nothing without the attending's approval. And the senior resident, okay? So don't get ahead of yourselves, all right, guys? All right. So here, this is your box where you put in your orders. All right, so this is, I typed into the order here, heparin, okay? So I want to place this person on a heparin drip, all right? So we talked about unfractionated heparin and when it's used. So I type in heparin, and what you see here at the very top is an order set, okay? So this is the order set that you're going to be typing, that you're going to be clicking on. It's called high dose infusion panel, and this is what's preferred here, okay? Heparin high dose, all right? So you'll click on heparin high dose, and then you'll open up this next box here. After you click on that, this opens up. This pretty much tells you stuff that's going to happen here. These are some orders for the nurse. The nurse is going to check neuro checks on the patient, okay? so that just in case, because their bleeding risk is going to be increased while they're on heparin, all right, make sure they don't get an intracranial bleed, okay? So they're going to do neuro checks on the patient. They're going to take bleeding precautions here for the patient as well. And then they'll notify you also if anything abnormal is taking place. So you make sure that all these boxes are checked. This is appropriate. And then going down this order set, right? Now, further down the same order set, we get to the heparin lab monitoring panels here. So you click down here on anti-10A. This is the one that you're going to be selecting, okay? There's anti-10A. There's a PTT as well down here beneath it. You'll click on anti-10A. This is what's preferred here at the hospital. This is anti-10A as the standard for heparin titration, okay? So this is how the nurse will titrate the heparin drip. They'll, from time to time, it will tell them when to measure the 10A levels, okay? This is how they'll titrate the heparin drip. So this is not something that you'll have to do. They'll do it themselves, okay? And this is how it looks like. The heparin drip is down here. These are also already checked. First, the heparin drip will start off with a bolus. The high dose has a 4,000 unit bolus. The other one, the low dose one, has a 3K bolus. So this is already checked. Leave all of this stuff. You want the bolus first, and then you want this. You want to come down here. This is going to be the titration table here that the nurse is going to follow. So make sure you click on this and everything. And this is going to be the maintenance drip that the nurse will follow. And this will tell her when to check the 10A levels, when to hold the heparin drip, etc. Sometimes the nurse will call you and ask you the 10A level is this and that. What should I do? So you can tell them to refer back to this table. Okay, so they have this. This will help them. All right. All right, the next thing is going back to that same order box that I showed you in the beginning. You can type in enoxaparin. So you want to order enoxaparin instead of a heparin drip, okay? So whenever you order enoxaparin, this is what you'll see here. You want it to be at a dose of 1 milligram per kilogram, okay? This is what's going to fully anticoagulate the patient, all right? There's other doses here, like a 40 milligram dose here. When would you use that? When would you use like 40 milligram daily? Yeah. Exactly. Yeah. DVT prophylaxis. Perfect. Yeah. So you'd use 40 milligram daily for DVT prophylaxis. What about if the BMI of the person is like 40? Yeah. You do 40 BID. You can do 40 BID if the BMI is 40 for DVT prophylaxis. Okay. So here I want to anticoagulate this person fully. Okay. I've decided that I want to use enoxaparin instead of a heparin drip. So I want 1 milligram per kilogram. And I want it to be down here, as you can see, every 12 hours. So I want it to be BID, all right? So make sure you click on BID, not daily, okay? And not once, right? And then going on. All right, so now what about if you want to just use oral medications, okay? You decided that you want to use apixaban, for example. And you want to use that, you can type in the box Eliquis or apixaban, and then you'll see the same thing at the top. You'll see these order sets. You'll come down here and you'll read, it says here, oral anticoagulants for AFib, AKA, and I'll say down here, across here, Eliquis, for example. And then you can click on that. That will take you to this window. And this, whenever you did that, that'll take you to an order window. They'll ask you, what do you want to do? You want to do 2.5 milligram BID? You want to do 5 milligram BID? Do you want to do 10 milligrams? Why would I want to do 10 milligrams of Eliquis? Yeah, for loading for a person who has a DVT, for example. That would be used for that, okay? 10 milligram BID, 7 days, and then transition to 5 milligram BID. That's for a person with a DVT PE, okay? So for a person with AFib, we'll click on that. And when we get to the orders, we'll choose 5 milligram BID or 2.5 milligram BID, okay? And then the next thing here is the metoprolol tartrate that we spoke about, okay? So this is the IV formulation that you want to use acutely. Your patient is in AFib, RVR. As a team, the attending has decided that they want to use this metoprolol tartrate. So you type in Lopressor or you type in metoprolol tartrate, and this is the window that will come up. And then you click here, 5 milligrams. You want to use 5 milligrams here. And then you can modify the frequency here, okay? And you can add administration instructions here as well for the nurse, okay? I've decided here that I just want to use it one time because I want to use it once and be a little bit cautious, okay? I want to see how this person's blood pressure responds, all right? So sometimes it's better to be cautious, just give one dose and see how the person responds to it, okay? Instead of putting in the administration instructions, for example, give it Q10 minutes times 3 and give all these instructions to the nurse about this and that, okay? It's better for you to just give it one time, all right? And not make the nurse decide, for example, if I need to give it or not give it based on this or that instructions. So it's better to be at the bedside, give it one time, see how the patient responds to it, okay? The next thing here is I want to order the diltiazem, okay? If you want to order diltiazem, you want to order amiodarone, you type in the names of the medications and you'll get this type of order set up here. It's called critical care medications, okay? This will have diltiazem, it'll also have amiodarone, it'll have other medications in it as well. So you go ahead, you click on that, and this is what you see. So there's telemetry here, there's boluses for fluid, person's hypertensive, there's vasopressor medications here, there's inotropes here, there's your antihypertensives here. Here's the diltiazem, okay? So you click on this diltiazem box here. Then down here you can see antiarrhythmics, you can see the amiodarone here. And then when you click on diltiazem, this is what opens up. You see how it automatically has 2 boluses here for you. So you can choose to give 2 boluses if you want to, okay? So it'll give directions to the nurse of when to give the second bolus here. It says give 15 minutes after the initial dose, okay? And then after that, there's a drip here. So this is the diltiazem drip. Make sure that you read through here that it also has the blood pressure, that you want the blood pressure to be checked every 15 minutes while the person's on the drip. Start the drip at 5 milligrams per hour, and then you titrate upwards, okay? And then the same critical care order set, I clicked on the amiodarone here, okay? So this is how you do amiodarone. You click it, and this is what you see. Next window. This is the order set. You see how the amiodarone has several different maintenance. It first starts off with a bolus. The bolus is 150 milligrams. So you give the 150 milligram bolus first to the patient. And then you can see that there's maintenance here. It starts off with 1 milligram per minute, and that lasts for 6 hours. Then it goes to 0.5 milligrams per minute, lasts for 18 hours. And then continues another 0.5 milligram per minute as well. Also, you want to get, they'll ask you how much amiodarone does a person need to get before you can transition them, if you want to transition to oral, at least like 10 grams through the IV, okay? Before you can transition the person to a PO. And this is my references, okay? All right. And thank you. Thank you. Sounds pretty straight to the point clinically, what I've experienced in my first year and second year, the medications that have been commonly used, the treatment plans that have been commonly used, the things that the cardiologist, the EP have told us, okay? So I hope you guys find that beneficial and you can just look back at that and hopefully answer some of the basic questions that your attending might ask you, okay? All right. Yeah. Sure.
So, for example, if you're ordering diltiazem and you initially start just with the okay. My question about the order set. For example, if we choose in diltiazem and we order in just one dose now, initially, but then later we decide to give one more dose. Do we just type in the order just one dose of diltiazem, or we need to also order it with the order set?
Yeah, if you just want to give one dose, the only way it comes up in the Epic is through this order set. You have to go back into the order set, just uncheck the drip and stuff, okay? You have to uncheck the drip, and then if you just want to use one bolus, you just check the bolus, okay? But this is where you find it. Anytime you type in diltiazem, it will be in that same order set, okay? You can't find it anywhere else. All right.
Quick comment. This was great, especially going through what it looks like on the computer. And this is a good foundation, especially working on floors.
Yeah.
One small slice or topic is, of course, we want to know, is this unstable or stable AFib, right? So for board testing, that's what we have to know in the moment for the patient. And then one subgroup is if they are stable, there still is a sense of urgency to address new onset AFib, because the longer you're in AFib, then you can have electrical remodeling. And so the harder it is to break AFib. So if this is new onset AFib, you do want to rate control, you do want to talk to cardiology, and you want to see if you can convert them earlier than later, because they'll have the highest success cardioversion. One small group of patients that we see in the hospital, you can have things that promote AFib, like sepsis, post-op, alcohol withdrawal, opioid withdrawal. And once you treat the underlying condition, the AFib resolves. It completely resolves. They don't even have an episode again. The EKG is normal sinus. So what do you do in those patients? Do you heparin drip, rate control, rhythm control? Do you go through this whole process? And the AHA and the ACC had good recommendations back in 2023 on this. But if it completely resolves spontaneously, it converts spontaneously, you didn't have to do chemical cardioversion, electrical cardioversion, and their CHADS VAS score is 2 or less, then the rule of thumb is you can watch them without anticoagulation, and you just have them follow up and do their thing. If same story, it resolves spontaneously, you didn't have to do any intervention because you treated the underlying problem, but you do a CHADS VAS score, and because of this and their comorbidities, their CHADS VAS of 3 or higher, then the rule of thumb is still consider doing anticoagulation on these patients, because that event was just a mask to show their higher risk for AFib. Once you have AFib, you have a 30% chance of having AFib again, just off the bat, even if it's from surgery, even if it's from sepsis. So it's a good topic to talk about inpatient. And for internal medicine, we do have a lot of control over it. So it's important to know these rule of thumbs.
Right, and studies and development have shown that in general, we are undercoagulating. Because people say, oh, it's an elderly, can have a fall, oh, I'm a bit afraid of it, and the newer medications are not as dangerous, so it's still a decision between the patient and the physician, but we should really anticoagulate if there's an indication, don't find excuses.
I have a question.
Yeah.
When you said the scores, so obviously for women, they will always have a score of at least 1. So was that taken into account with the 2?
Yeah. So
Please repeat the question.
so biological sex changes the CHADS VAS score. And so typically just gender, female, you're going to have a higher, consideration and vice versa. So yeah, that plays a role, because that may bump you up to a score where now you're going to be on permanent anticoagulation. So yeah, exactly.
I don't have an answer, but I have a question. Probably they don't know either. How about transgender? Are they counting the risk on ground of the birth gender, or on ground of the transfer into the other gender? Like a trans woman is now receiving high estrogen,
In general, hormone replacement therapy increases your
Yeah.
chances as well from blood clots. So I
Right.
imagine it will increase your risk, but I don't know if there are studies.
Exactly. I don't know about studies either. That would be something.
I think you get a point. The new CHADS VAS score is thromboembolism event too, where it used to just be, now it's more broad. So if you're on something that increases your risk, maybe you get a point.
Yeah.
I would probably give them.
Yes, I think I would guess, yes, but we don't know exactly the answer. We should look it up.
And on the same note of us using anticoagulation less than normal, there's 3 populations where you don't need to calculate a CHADS VAS score. You go ahead straight away and anticoagulate them. One of them is the valvular AFib. Those you go straight away with warfarin. The others are patients with HOCM, hypertrophic obstructive cardiomyopathy. You anticoagulate right away, and cardiac amyloidosis. The other thing also is CHA2DS2-VASc in general is non-modifiable. So the risk factors there, you can't change it. If you have a high CHA2DS2-VASc score, you can't really change it. As blood, on the other hand, you can control a little bit factors there because the hypertension is if it's poorly controlled. So if you control their hypertension better, they lose that point. One of the criteria there also is alcohol use. We can just counsel them not to drink alcohol. The other one is medications. So these are a lot of things that you can change to make their bleeding risk low.
As far as like rapid response calls go, is there a rule here for like, if like the patient's in AFib with RVR and like their heart rate is above a certain, like over 200, even if they like look okay and they're talking and stuff, like, is there like something that we need to call rapid response above a certain?
Yeah, that would be rapid response. Yeah.
To answer your question, Dr. Keith, I was just looking, they, for this specific issue, they made the chats back without the fast, without the S, without the sex. So this is to kind of neutralize this problem as well.
I didn't know. So there's a specific
Yeah.
chat class
But
with
without the- Yeah.
without the gender in it for transgender
Yep.
population. Great, thank you. I learned something.
And that's resources scored.
No, this is the the Journal of Cardiovascular Electrophysiology. Thank you, Jack.
Very good. Oh, yeah, that's the.
Thank you.
The cutoffs are different. I mean, for men, the cutoff is for women, the cutoff is 3.
Yeah.
Women already get a point just for being women. The main thing is the CHA2DS2-VASc number itself is prognostic. It tells you your chance of having blood clot. So females in general have a higher risk. So not only to help you decide, but it also gives you an idea of what's your risk of developing blood clot.
Yeah, just to add something, like sometimes patients come from home with AFib and they are on anticoagulation most of the time, Eliquis, and they are here because NPO because for surgery or something. So you have to stop Eliquis at least 2 days beforehand. So now they were already at home on drug or Eliquis. So the way you start the heparin is you stop the Eliquis, and when the next dose is due, you resume the heparin without bolus. So that's how like you do the anticoagulation. And you can get that information from Lexicon. If you go there, they will tell you whether you are transitioning from warfarin to heparin. There's a different like dosing. If you're going from dual to like the Eliquis to the heparin, there's a different indication. So you follow with them, okay?
Where is lexicon found?
Yeah, it is like up to date. There's another, it's I think related or connected with the up to date lexicon, LEXICOMP. And do we have like, can you show it?
It's on Epic.
Yeah, it's on Epic.
And you all will receive, if you haven't received already, a subscription for an app called Amboss. Right? The Amboss, we will have an official introduction to this app on your phone. It's privately on your phone. It's not connected to Epic. But this Amboss has a lot of these answers in it too. Plus, it has the preparation questions for USMLE for free and for what?
ADN.
And ABIM, exactly right. So we will talk, and I think the appointment is soon when we get explanation how to use it. But it's an evidence-based tool. That's it, correct?
That's it. Yeah, thank you. Yeah.